Good afternoon, dear all the participants. We welcome you all for the today's RDLS session on guidelines for the management of HIV associated malignancies. Today we have with us Dr. Nilima Shah, who is professor and head of unit Department of Medicine and Medical College, Ahmedabad. Now I would request Madam to kindly come this session.
Thank you, Doctor. So today's topic is a malignancy associated with the PLHIV. What are the guidelines and what is the management for the all the malignancy? We have a big list of the malignancy. If I look at the introductory aspect, all the malignancy means Kaposi sarcoma to NHL to HL to skin cancer, cervical cancer. The common thing I would like to say that is we have to suspect first to whom we are seeing this type of the malignancy. So what are the symptoms? Some malignancies are associated with the some viruses also. So that is also to be isolated. Throughout the lecture, we'll go through it in detail. We have a staging, we have a diagnosis. So clinical diagnosis, staging, as well as the survival rate. All the malignancy, chemotherapy is given or radiotherapy is given or chemoradiotherapy or some surgical intervention. When patient is having malignancy associated with HIV, so already immunocompromised status and chemoradiotherapy has been started, usually the chances of some opportunistic infection or bacterial or fungal is more. So when patients are on this therapy, we have to monitor that also. And from our side, we have to give some prophylaxis also. So that is main aspect, and to whom we have to suspect, that will go into the detail. The death rate is there, already there with the all the cancers, but when there is a CD4 count is less, usually we see the much of a mortality. Some cancers are age-defining illnesses and some are not. So what are that? Kaposi sarcoma, high-grade B-cell non-Hodgkin's lymphoma, and invasive cervical cancer. They have been designated as a AIDS-defining malignancy. This accounts 1/3 of the older deaths in HIV patients. HIV will have a higher risk to die from a tumor when there is a non-Hodgkin's lymphoma rather than AIDS-related infection. So when there is a NHL, patient may die with the risk due to the tumor. So what is first thing? What is the Kaposi sarcoma? The lesion usually involved mucous membrane as well as the cutaneous membrane. So mucocutaneous disease may be involvement in the lymph node or even other organs also. So I told that some viruses are associated with the malignancy. So this is caused by the Kaposi sarcoma herpes virus, KSHV. The lesions appear mostly on the face, especially on the nose, genitalia. They have a typical hues, including pink, red, or purple brown. This is the with the centrally little bit of a pit. So from that we can identify. So all the cancer, first we have to suspect, then we have to diagnose, then we have to stage, and from that staging we are giving some further therapy. So how to diagnose? It is based on the characteristic clinical appearance, means mucocutaneous lesion, but histological confirmation is always required. Extracutaneous spread is seen in 1/3 of the patient, 15% in the oral cavity, 40% in GI tract. Even in pulmonary and lymph node involvement also is there. So when there is a occult blood in the stool, it is a and GI involvement suggests. And when there is a cherry red nodule on the bronchoscopy, it is strongly suggestive of the diagnosis of Kaposi sarcoma. So histopathological grading means gross. It can be patch, plaque, or nodule. The risk stratification is based on the tumor size, means T0 or T1, immune status, that is I0 or I1, or systemic illness, S0 or S1. Detail will show in the next slide. Staging include complete inspection, including oral, genital mucous membrane. We require abdominal ultrasound, chest radiography, and if mucous membranes are involved, then gastroduodenoscopy and colonoscopy is required. So if we don't have ultrasonography at our level or this thing, when we suspect, ideally we have to refer the patient to the higher center or to the hematologist or cancer institute. So first, what is T0 tumor? It is a localized one having a good risk. T1, they are the widespread one. So Kaposi sarcoma, when there is a skin or lymph node, means only bean size collection. When there is an involvement of this much thing is a localized. So it is in the palate or roof of the mouth. They are the flat rather than the raised. If it is a T1, poor risk, they have a more than one of the more of the following, means edema, extensive oral, not flat, they are raised one, they have a roof of, in the roof of the mouth also, and inside more also, means raised one, as well as the lymph node involvement. In the lung also, in the intestine, liver, and they carry worse prognosis. So what is the immune status? Good risk means CD4 cell count, if it is more than 150, then it is a good risk factor. If they are 150, less than 150, they are poor risk. So in good risk, systemic illness, no systemic illness present. So there is a no history of opportunistic infection, even thrush or fungal infection in the mouth, no B symptoms. B symptoms are the unexplained fever, mainly the night sweats, and weight loss. So weight loss of more than 10% without dieting. Though patient are on ART treatment, they have some symptoms like this also. We have to always identify whether it is tuberculosis, whether it is lymphoma. So that's why even when we see the lesion, we have to go for a biopsy. The KPS score, that is a Karnosky performance status score. This score is considered as a, if say more than 70 or higher, then it is a good thing. If it is less than, then it is a bad thing. This score include how the patient well-being, whether patient is able to do the routine his work or not. So if he is taking care of him or herself, then the score is 70. The highest is 100, means patient is normal. The lowest is 0, that is dead. 70 is in between. So patient is able to do his own routine work. But in 40, patient has to take, patient needs to be taken care by somebody. So poor is the thing as well as the other infection, and one or more B symptoms are present. So what is to be done? Therapy. You have diagnosed the thing, you have this thing, staging also. The local therapy may be most useful for the localized bulky lesion, but if it is a more, then we have to go with the other therapy. This alliterated noin gel 0.1% is the only topical administered therapy is approved. This contain it is a retinoid that is binds with the retinoic acid receptor and retinoid X receptor, and it acts on the cutaneous level. This patient require 4 to 8 weeks of therapy. The side effects can be dermal irritation as well as some undesirable skin lightening when a person is having a dark skin. So alternative treatment can be local intralesional chemotherapy, radiation therapy, laser therapy, or cryotherapy. The only recommended alternative local therapy with the excellent response, 70%. So what are the other systemic things? When there is a systemic involvement, means lymph node, liver. So liposomal doxorubicin and adenorubicin are the recommended as a first-line chemotherapeutic agent. The dose is 20 milligram per meter square every 3 weeks for doxorubicin, and for adenorubicin it is a 40 milligram per meter square every 2 weeks. If the anthracycline means if the resistant disease is there, then we have to go with the paclitaxel. The dose is 100 milligram per meter square every two weeks. It is not recommended to use interferon therapy for Kaposi sarcoma in a view of poor tumor response and the drug-related toxicity. So this is the lesion, oral lesion, and after treatment, we are seeing the regression in the disease. So what are the recommended thing? Local radiotherapy or intralesional wind blasting, chemotherapy in T1 advanced stage, liposomal anthracycline first line. If they are resistance, then we have to give paclitaxel. This all thing is to be decided by an expert person only. The next thing is a systemic AIDS-related non-Hodgkin's lymphoma. PL-HIV have an increased risk of developing non-Hodgkin's lymphoma. They are diffuse large B-cell lymphoma, that is known as DLBCL, Burkitt's lymphoma, leukemia, means BL. They are considered as a AIDS-defining illnesses. Despite the decrease in the incidence of AIDS-related lymphoma with increasing ART use, so when persons are aware they are using ART, the first thing, sometimes patient may directly come as a first ADI, so AIDS-related illness with a lymphoma. So lymphoma is diagnosed with PL-HIV for the first time. This has increased. So to whom we have to suspect? When there is an older age, low CD4 cell count, and no prior treatment. So they are coming for the first time. They have an advanced clinical stage, presence of B symptoms, extranodal involvement, including bone marrow. So that's why we have to go for bone marrow biopsy also. So what are the lymphoma? Immunocompetent patient, Burkitt's lymphoma, large B-cell lymphoma, Hodgkin's, others are mild lymphoma, peripheral T-cell and NK cell. Lymphoma occurring more especially in a HIV patient, that is primary effusion, plasmablastic, lymphoma arising in HHV-8 associated multicentric disease, that is Castleman disease, lymphoma occurring in a other immunodeficient state, polymorphic lymphoma, lymphoid proliferation resembling post-transplant lymphoproliferative disorder. So EBV and HHV-8 are common viruses. They are affected. The patients have a positive virology. So here a person having a multiple bilateral freely mobile non-tender from 1 to 3 centimeter lymph node with a normal skin over the swelling in a cervical area. So if we look at the X-ray chest, there is a mediastinal widening due to multiple enlarged mediastinal lymph node. CT abdomen shows multiple node in left para-aortic aortocaval region, small rounded hypodense lesion in anterior aspect of the upper pole of the right and mid pole of the left kidney, and lymphomatous deposit in a left pleural effusion. So these all, so only lymph node, if you are suspecting, then you have to go for X-ray as well as the USG or even CT scan. So apart from the usual tests, the evaluation and clinical staging of ARL require CT scan, bone marrow aspiration and bone marrow trephine biopsy. Though as a person, as a medical officer, person is not doing, but at least he or she has to suspect, and timely reference should be made when this type of the clinical situation arises. So PET scanning for staging accuracy. When to do CSF examination? It is not recommended in all, but if there are signs of some CNS involvement or involvement of paranasal sinuses or involvement of breast, epidural or testicular, because these all can lead to secondary CNS involvement also, and we have to go for a virological testing. So if we look at the table, mainly Epstein-Barr virus is there, and with the Castleman disease there is a HHV8. Otherwise, almost in all EBV virus is associated. So diffuse large B-cell lymphoma. This is the most frequent ARL. Thank you. This is most present at advanced stage with the B symptoms, as well as extranodal tissues are also involved. So how to define the prognosis? It is from the patient person himself, lymphoma, which type of the lymphoma, and there is a HIV, means viral load, as well as the CD4 count. The International Prognostic Index, IPI, has been extensively validated and remains a reliable predictor of outcome. These index include so many things. They have given 10 points to each one, means age, sex, immune status, the staging, type of the lymphoma or type of the cancer. So overall, if it is more than 450, then it carries good prognosis. Low CD4 counts have been reported to be a predictor of poor survival in several studies. As such, also when there is a low CD4 count in PL-HIV, then also patient is having a more chances of other infections also. So what are the recommended treatment? ART has led better immune reconstitution and hemopoietic growth factors, GCSF. So that is a granulocyte stimulating factor, because all the chemotherapeutic agent will lead to depression in a bone marrow. So bone marrow suppression is there. So when we give these growth factors, then we have a better chances to give the chemotherapy. So otherwise we can't use these conventional because they are the myelotoxic one. So what are the first line treatment? We all know, even we have learned the things, that is a CHOP and EPOS, that is a cyclophosphamide, doxorubicin, vincristine and prednisolone plus rituximab. So RCHOP and dose adjusted etoposide, prednisolone, vincristine, cyclophosphamide and hydroxydenarubicin plus rituximab. So when we talk about RCHOP, it is a rituximab with this cyclophosphamide resin, and DAREPOCA, that is a dose adjustment therapy. Why it is required? Because neutrophil count and other hematological toxicity when patient is on this therapy, we have to monitor. So what is the treatment? When there is a localized disease or stage 1, the combined modality treatment with 3 cycles of chemotherapy followed by radiotherapy, or 4 to 8 cycles of chemotherapy alone. When there is a disseminated disease, so either it is a RCHOP or DAR-EPOCH, advocated as a first line, maximum 6 cycles to be given or 2 cycles more. So maximum 8, not more than that. Addition of rituximab to chemotherapy is now routinely recommended for DLBCL with appropriate antimicrobial prophylaxis, as well as this granulocyte stimulating factors, because it suppresses the marrow, as well as there are more chances of bacterial as well as fungal infection. So that's why antimicrobial therapy is required. When there is a refractory disease or relapse, this is localized, then disseminated, and then patient is not responding, then these also to be decided by consultant only, but the treatment options are high doses of salvage resin, such as ICE, that is eposamide, cisplatin, and etoposide, DHAP, dexamethasone, high dose of cytarabine and cisplatin, then ESAP, etoposide, methylprednisone, that is solumedrol, or high dose of cytarabine and cisplatin, and GDP, that is a gemcitabine, dexamethasone, and cisplatin with rituximab. If patients are chemosensitive to the disease who are eligible for the transplant, they should proceed to the autologous stem cells transplant. So in all the things, when there is a chemotherapy, if not responding patients, then we can go with a higher dose or some different regime. Even then, because this is a very complex phenomena. With PL-HIV, even without PL-HIV also, patient may go with the marrow toxicity. Even when patients are on chemotherapy, they should receive some antimicrobial, also some vaccines also if required for some pneumonia. So all this is a vicious thing. So if patients are good enough for go for autologous stem cells transplant, they should be advised. It is to be advised by expert person. So how to assess the response? Complete response, partial response, or stable disease, or relapse. Complete means there is a radiological clinical disappearance of the disease and PET is negative. Partial means more than 50% decrease in diameter up to the sixth of the largest dominant masses. PET is positive in a previously involved site. So PET scan is positive, the site what is previously involved, but the diameter is decreased. In stable disease, there is a failure to attain either complete response or partial response. And relapse, there are new lesions or there is an increase of more than 50% of a previously involved site. So these all we have to just know that how the disease progress. So what are the recommendations? Again, the chemotherapy as a first line, it should be combined with the ART. Closer surveillance is mandated for those with the CD4 is less than 50 cells. Patient with relapse, refractory disease to be proceed for autologous stem cell transplant, that is ASCT, after high dose of therapy. The last sentence what we have in a previous slide. PET scan should be performed at the end of 4 to 6 weeks of the therapy. Now, Burkitt's lymphoma. This is second most common subtype of ARL. It occurs in individuals with relatively preserved CD4 count. Presentation, poor performance status, as well as the high lactic dehydrogenase level. In all cancerous patients, this LDH level is important. Extranodal involvement is also common. The incidence of CNS involvement is ranges from 8 to 28%. The regime is used is CODOX-M and IVEC. So what is CODOX-M and IVEC? Cyclophosphamide, vincristine, doxorubicin, high doses of methotrexate or eposemide, etoposide, and high doses of cytarabine. It consists of 4 cycles. In that, 1 and 3 involves CODOX-M and cycle 2 and 4 involve IVEC. So it is an alternate therapy with the this agent. Each cycle lasting until the blood count recover, means neutrophil count should be more than 1000 and platelet should be more than 1 lakh. If the patient is of a low risk, then 3 cycles are can be enough. High risk should receive 4 total cycles. To overcome the concern of treatment toxicity in HIV associated, the DAEPO regime plus rituximab may be considered. So the dose adjustment regime with the EPOCH. So who are the low risk patients? If they have a normal LDH, stage 1 or 2 disease, WHO performance score is 0 to 1, and number of extranodal sites is less than or equal to 1. From this, at least 3 factors should be there. Then they are considered as a low risk disease. If it is raised LDH 3 or 4, performance is 2 to 4, or more than 1 extranodal site, they are from these 2 or more, then they are considered as a high risk disease. So what is recommendation again? It is a chemotherapy agent, either with the CODOX-M, IVEC or DAR EPOH as a first line. Chemotherapy regime should be combined with ART. So there is no problem when we give the ART over here. So that prevention of secondary CNS lymphoma. Use of intrathecal, that is IT, prophylaxis with methotrexate and or ARCC has been long considered as a mandatory part of systemic treatment for all HIV infected patients with non-Hodgkin's lymphoma. So they are to be given prophylaxis of a methotrexate. So advanced stage, elevated serum LDH, extranodal disease, involvement of testes, paranasal sinuses, paraspinal location, breast involvement, renal involvement, epidural space and bone predict a higher likelihood of CNS relapse. CNS prophylaxis should be reserved for those who need it based on the site of the involvement stage and histological subtype, not all. So all patients with DLBCL should receive CNS prophylaxis, means either it is IV or it is intrathecal. All patients with Burkitt's lymphoma should receive CNS prophylaxis. What is tumor lysis syndrome? Those with DLBCL, elevated LDH, when they have a bulky disease, and those with the Burkitt's lymphoma or leukemia with a stage 3 or 4 disease, when treatment is started, they start with the tumor lysis syndrome. To prevent that, we have to give adequate IV fluid. Then first dose of resveratrol should be administered 4 to 24 hours before starting the chemotherapy. This is given as an intravenous infusion over 30 minutes and should not be given as a bolus infusion. Repeated dose should be used if the serum uric acid levels are more than 7 mg per dl during the 96 hours after the receiving of the first dose. Those who don't meet the criteria for high-risk disease, they should be adequately hydrated before therapy, as well as allopurinol may be given to decrease the serum uric acid level. So what are the relapse or refractory age-related lymphoma and what to do with that? In the absence of any standard second-line chemotherapy regime, various aggressive regime means with the platinum is tried. So what are the common regime? That is dexamethasone, high dose of cytarabine and cisplatin, efosamide, cisplatin and etoposide. They are the usually combined with the rituximab. Although the value of rituximab in those who relapse early or after refractory upfront treatment with rituximab is less clear. In that patient, we have to go with the high dose of the therapy or transplant. So for those who respond, studies have shown that consolidation with the high dose therapy and autologous stem cell transplantation is a optional therapy. So what is the again recommendation? Those who are fit for the intensive chemotherapy, they should receive second line regime, which may contain platinum, or those who receive complete resolution or partial with second line therapy should be considered for high dose therapy with the stem cell transplant. Primary central nervous system lymphoma or PCNSL. So, what is the clinical presentation, diagnosis, and radiology? Subtype of DLBCL with a post-germinal center phenotype confined to the craniospinal axis without systemic involvement. So, they are primarily CNS disease. There is no other thing. So, brain is involved. So, it can affect any part of the brain. Meninges, cranial nerves, eye, cord, anything. So, presentation will be from these only. So if brain meninges involved, then neuropsychiatric signs, increase intracranial pressure, ocular symptom, or some cranial nerve means palsy also can be there. Serum LDH and CSF analysis should be done when lumbar puncture can safely be performed. Otherwise, brain biopsy for the definite diagnosis, not always recommended, but we can go with the other radiological diagnosis. So detectable EBV virus in a CSF, consistent radiological finding in a severely immunosuppressed patient, it is sufficient for the primary CNS lymphoma. MRI is the most sensitive imaging modality and shows single 65% or multiple lesion in a non-enhanced T1 weightage images and hyperintense tumor and edema on the T2 flare images. So they are look like a toxoplasma. So that's why the diagnostic algorithm for the management of the cerebral mass lesion in HIV patient include 2-week trial of anti-toxoplasmosis therapy. That is sulfadizine 1 gram QID and pyrimethamine 75 milligram OD. So when there is a tumor-like thing, we have to give this therapy. If not responding, then go for CSF. If the EBV is detected, then it is a primary. So HIV positive patient with primary CNS lymphoma usually have advanced immunosuppressions, means CD4 count is less than 50 cells. This making impossible the administration of a high dose of methotrexate even and cytosine arbitrate because CD4 is very low. So we can give rituximab as a alternative treatment. If induction treatment is well tolerated and response is documented, consolidation with the high dose of the therapy with a stem cell transplant should be considered. So what is the recommendation? Again, if a person is having a less CD4 count, then we have to take care of that part or rituximab, or we can go with the methotrexate high dose with other chemotherapy agent. ART can be continued, or lastly we can go with the whole brain radiotherapy as a palliative treatment modality for the control of the symptoms as a alternative first line treatment when there is a risk of toxicity of high dose intravenous is there. Primary effusion lymphoma. So primary effusion lymphoma is a rare B-cell lymphoma characterized by effusion. It can be in the pleura, pericardium, or peritoneum. So patient will be presented at effusion, pericardial effusion, or ascites without identified tumor masses or lymphadenopathy. So common thing can be there as a tuberculosis also when we parasynthesize them. The low CD4 count is common, and HHV8 has a pathogenetic role and it present almost in 100% of the cases. So if you are suspecting effusion, if it is tuberculous one, then it's okay. Otherwise, viral disease as well as we have to go for a diagnosis, means cytological diagnosis. So what is the presentation? Patient may have abdominal distension, dyspnea because of pericardial or pleural effusion. So how to diagnose? Cytological analysis of effusion. Fluid reveals tumor cells that are large, round to irregular nuclei with nucleoli and have a appearance of the immunoblast, plasmablast, and or anaplastic forms. These all thing is diagnosed histopathologically as well as histochemical examination is required. So detection of evidence of viral infection also there. If it is a HHV8, then you can go with the immunohistochemistry. In that, latency associated nuclear antigen, that is LAN1, or it is a standard detecting HHV8 in a sample. So what is to be given? In absence of any standard treatment, PEL is in HIV to be treated with a CHOP regimen. ART should be administered concurrently with the such type of the treatment. Then plasmablastic lymphoma. Plasmablastic is a rare variant of DLBCL with plasmocyte appearance. This is affecting primarily the mucosal site or oropharynx in the male with the HIV. There is a 3 histological subtypes are there. Monomorphic plasmoblast with minimal plasmocytic differentiation, predominantly affecting the oral cavity. Those with the more plasmacytic differentiation involving extraoral sites and means oral local, extraoral, and third thing is the nodes as well as the spleen. So that is associated as a Castle-Man disease. How to diagnose? Immunohistochemistry positivity for cell markers. So the tumors are having some cell markers, like when we go with the histopositivity. So this is VS38C, CD38, multiple myeloma, oncogene, CD138, and constant presence of Epstein-Barr viruses. The absent expression of leukocyte common antigen CD45 or the B cell markers means CD20, CD79A, PEX5 serves to distinguish between the plasmablastic lymphoma from the immunoblastic variant of DLBCL and extracavitary variant of primary effusion lymphoma with the plasmocyte differentiation. But these all to be done at a tertiary cancer institute like consultant. It is not with the only with us. So we have to just take care of that part. So what is the treatment? Again, CHOP-like treatments to be a standard of care. But due to disappointing long-term survival rate, more intensive regime has been suggested, such as hyper-CVAD, that is a cyclophosphamide, vincristine, doxorubicin, dexamethasone, or what we have previously seen, that is Codox-M or IVAC. CHOP-14, shortening the time between cycle from 21 days to 14 days has been found to be more effective in the recent year. So plasmablastic lymphoma should be treated with the intensive chemotherapy as an option, followed by radiotherapy, at least in a localized stage. So early consolidation with the autologous stem cell transplant might be option for advanced disease. So really little bit, if we even heard, if we read some complicated things, but the end I would like to say, we have to suspect first, then we have to refer, then we have to think of diagnosing, staging, treatment, whether primary is effective or not. Then we go for the secondary one, if it is effective or not. Then third thing is a transplant, autologous stem cell transplant. If that is also not possible, then the palliative thing can be given. The cervical intraepithelial neoplasia, that is known as CIN, and cervical cancer. So when there is only epithelial involvement, that is a CIN, or when there is invasion, it is a cervical cancer. It is a common in HIV patient with an earlier age of diagnosis, aggressive course and poor treatment outcome. Cervicovaginal HPV infection has been reported to be higher in HIV positive, that is 60 to 55%, than with the HIV negative, 25 to 30%. ART has a minimal effect on the incidence of invasive cervical cancer, but has effectively brought down the incidence of CIN in a woman with HIV. So if when person is already taking ART, they have a less incidence of a CIN. So if we go at the algorithm, this algorithm in later 2 slides, they have divided into 2. So first we have to visualize it. So visualization by acetic acid at a pHC level. So if it is positive, then what to do? If it is negative, then what? So VIA, if negative, then repeat after 5 years. Go with the health education. If negative, then nothing is required. If it is positive, then refer the patient to DH or district hospital, where we can go with the pap smear and colposcopic examination. So if colposcopy is normal, then not required further. But if it is abnormal and there is a CIN in colposcopy, then we have to go for cryotherapy. If person is not suitable for cryotherapy, then this is a leap therapy, and we have to follow up the patient for the pap smear and biopsy. If patient is suitable for the cryotherapy, then go for cryotherapy and go for punch biopsy. So that we'll look in the next slide. So this is the same slide. So leap therapy is a loop electrosurgical excision procedure. So if we have done follow-up after 1 month with the pap smear and biopsy, if malignancy on biopsy, then refer to the higher center, medical college or cancer institute. If there is a only CIN, then follow up after 1 year for PEP and treated for CIN, then follow up for means treated for CIN means if cryotherapy or a loop therapy is given. If normal PEP with a low grade squamous cell, then to be followed 1 yearly. If there is a high grade PEP smear, then we have to repeat the colposcopy and punch biopsy. If positive, then again cryotherapy and loop electrosurgical excision. This is for CIN only. If there is a cervical cancer invasive, then we have to go for a surgical resection. So what is the pathology behind this? HPV 16 and HPV 18 encodes for 3 oncoprotein, E5, E6, E7 that stimulate the growth, and they have a transferring property. The integration of HPV DNA within the host genome result into the chromosomal instability, and they follow the progression from this just to CIN to invasive one. So HIV mediated immune suppression prevent the clearance of HPV and that leading to increase of a replication. So that's why CIN to invasive is common. So nowadays we have a three major alternative for screening: cytology, HPV testing, as well as cytology and HPV post testing. So how to treat the patient? Treatment of cervical cancer includes surgery, radiotherapy, and chemotherapy. Surgery including radical hysterectomy, lymphadenectomy when there is an early stage. Treatment of locally advanced cervical cancer include radiotherapy, that is external radiotherapy and brachytherapy and chemotherapy. The recommendations, what to be done when we see the patient? Screening cytology for HIV positive woman is recommended at the time of diagnosis and annually thereafter. If 3 annual pap smear are negative, it should be repeated every 3 years. Colposcopy should be performed if abnormalities are seen on pap screening. The treatment of CIN or invasive should be follow the same guideline as those advocated for the normal one. So there is no change when there is a PLHIV. Anal cancer. The incidence of anal cancer in PLHIV is up to 40 times higher compared with that of the general population. This is occurring even at a much younger ages with the highest risk in men who have a sex with the men. Anal cancer can present with the rectal bleeding, anal pain, incontinence when there is an anal sphincter is affected. The pathogenesis resembles that of cervical cancer with HPV infection leading to an intraepithelial neoplasia, that is known as AIN, and ensuring progression from low to high grade dysplasia and subsequently the invasive cancer. So when it start, there is a low grade thing. So grade 1, 2, 3 in the next slide. So first it will be like a cervical invasive cervical cancer like thing, then it become invasive. Here also only epithelium, then it occurs as a invasive one. So grade 1, 2, 3, this is low grade squamous epithelialization, this is high grade. When there is a lower 1/3 is involved, it is grade 1. Lower 2/3 of the dysplastic cell involved, then grade 2, and entire epithelium, then it is a grade 3 cancer. So classification in NI cytology according to the Bethesda classification. N is normal, S case US, that is the atypical squamous cell of undifferentiated, undetermined significance. S case H is atypical squamous cell, cannot exclude SCIL, means high grade this thing. Low grade squamous intraepithelial lesion. In HSIL, it is a high grade. And CA is a squamous cell carcinoma. The treatment. Primary surgery has nowadays been replaced by concomitant chemoradiotherapy, CRT, that is chemoradiotherapy. And these achieve local control as well as the sphincter preservation. Primary tumor resection is restricted to small tumor of the anal region. If there is a small tumor, then it can be resection can be done. Chemoradiotherapy in HIV patients should be performed according to the current guideline for non-infected. So the therapy will remain same. Intensity modulated radiation therapy, it is IMRT, or volumetric modulated arc therapy, that is known as VMAT, with a stage adapted dose of 50.5 to 59.4 gray. This GY is a gray. It is a unit of radiation. 1 gray is equal to 100 radiation. Is combined with the chemoradiotherapy in the first and 5th week. Usually consisting of 5 into 1000 milligram per square with 5 FU with mitomycin C on day 1 and 29, provided the number of CD4 is not less than 100 to 200 and the performance status is adequate. Because of nephrotoxic potential of MMC, tenofovir should be used with caution and zidovudine should be avoided in view of possible bone marrow toxicity. So here our concern is that when patient is receiving mitomycin C, tenofovir should be used in caution, and we have to go with the renal function test and zidovudine for bone marrow toxicity, because in that also we have to go with at least with the CBC. So monitoring and follow-up. Evaluation, MRI imaging of the pelvis examination under anesthesia, clinical evaluation and review continue every 3 to 6 months for 2 years, every 6 to 12 years. Residual primary disease or local recurrence after CRT demands salvage therapy involving the abdominal resection if there is a disease in advance. Patient with metastatic disease or local relapse following salvage may consider for palliative chemotherapy. If the tumor or the stage is not resectable, then we have to go for a palliative therapy. So what are the recommendations? Again, when there is anal cancer, we should examine under anesthesia, CT and MRI to be performed to assess the regional nodes and tumor extension. High resolution endoscopy service should be available. CRT with 5-fluorouracil and MMC is a first line treatment, means chemoradiotherapy with chemo, this thing, along with ART and opportunate infection prophylaxis. When there is a more disease, then we have to go for the salvage therapy. Best supportive care should be advised for metastatic disease and local relapse following the salvage surgery. So now Hodgkin's lymphoma. The Hodgkin's lymphoma is one of the commonest tumor among the non-AIDS defining cancer. 10 to 20% fold increase incidence in HIV patient in comparison with the HIV negative population. Here viral load is not that important, but CD4 count do take part. So if less than 200 cell per millimeter cube, then there is a chances of Hodgkin's. The risk of developing Hodgkin's lymphoma remains same while on ART, and HL incidence rates are higher in the first few months after the starting of ART. Viral load has not been shown to relate with the incident rate. So what is the characteristic of Hodgkin's lymphoma in HIV? There is a more extranodal involvement, especially the bone marrow. So bone marrow examination is required. High frequency of B symptoms, poor performance status, and advanced stage at the diagnosis. So this is the things we have to keep in mind. So how to diagnose? Diagnosis of HL maintenance tissue sample biopsy. So when any patient come with the lymphadenopathy, though it is AIDS related, though it is tuberculosis related, or it can be a lymphoma. So that's why the biopsy is must. The Ann Arbor classification and Cotswolds modification require blood test, whole body PET scan, and unilateral bone marrow biopsy in a view of higher chances of bone marrow involvement. So stage 1, 2, 3, 4 disease are when there is a single lymph node involvement, the stage 1. When there are 2 or more lymph nodes, but on the same side of the diaphragm, it is 2. When there are more involvement, but in the both the side of the diaphragm. When there is a extranodal, means involvement, that is known as E, or it can be disease, either single or more. X is a bulky disease, widening of more than 1/3 of the mediastinum as T5, T6 level. And A, B means absence or presence of B symptoms, means weight loss, fever, night sweats is present. So how to manage the person? Again, we have to go with the chemotherapy as well as the radiotherapy. The ABVD, that is adriamycin, bleomycin, vinblastine and decabrizin. And IFRT means it is a involved field radiotherapy, means whatever field is there, we have to give radiotherapy to that. So the dose is like this: early favorable, then it is ABVD 2 to 4 weeks with 2 to 4 cycle with 20 to 30 gray, unfavorable 4 and 30 gray, and for advanced we have to give for 6 to 8 cycle with the radiotherapy, because in that case the disease may be more involved. So what is recommendation? PVD is the first line chemotherapy. Good performance patient with relapse refractory should receive salvage chemotherapy, and if the disease proves to be chemosensitive, the treatment should be consolidated with the high dose therapy or autologous stem cell rescue. ART should be co-administered during the chemotherapy. PI-based regime should be avoided to minimize the additive toxicity like vinblastine and mediated neurotoxicity as well as the neutropenia. So again, we have to take care of PI-based regime. The PCP, Mycobacterium avium prophylaxis and fungal infection prophylaxis during and after chemotherapy, because these all will lead to again the secondary infection. Assessment of response after treatment should be performed by PET scan and bone marrow biopsy. Follow-up should be performed every 2 to 4 months during the first 2 years, then 3 to 6 months for 5 further years. So at least 5 years of the follow-up is required. Multicentric Castleman disease. The Castleman disease, multicentric is a group of disorder that shares the characteristic histopathological features but have a wide range of etiology, presentation, treatment, and outcome. Here, HHV8 is common. So, MCD is relatively rare lymphoproliferative disorder that classically present with fever, anemia, lymphadenopathy, and it is more common with the HIV1. So, malaise, night sweat, rigor, fever, anorexia, weight loss. Clinically, patient may have a lymphadenopathy, hepatosplenomegaly, ascitic, edema, pulmonary and pericardial effusion. So even if we look at the differential one, here we may have a disseminated tuberculosis, patient may have a hypoproteinemia with liver disease. So all this we have to look for, and we have to go for a biopsy, because in this lymph node biopsy is very important. So thrombocytopenia, anemia, hypoalbuminemia, and hypergammaglobulinemia is present. So classification, it can be classified as a unicentric or multicentric. In multicentric, it can be idiopathic. Again, it is classified into two things. So idiopathic, that is IMCD, idiopathic multicentric Castleman disease. TAFRO. So what is TAFRO? Thrombocytopenia, ascites, fibrosis, and renal dysfunction. If not specified, then it is known as IMCD, not specified. HHV8, human herpes virus 8, is associated with the MCD. Or it can be polyneuropathy, organomegaly, means poem-like syndrome, endocrinopathy, monoclonal plasma cell disorder, skin changes, like that. So how to diagnose? MCD can only be established definitely by lymph node biopsy. The characteristic onion skin appearance and interfollicular plasmoblasts that express the HHV8 latent nuclear antigen. These plasmoblasts also express high level of lambda light chain restricted immunoglobulin M, that is IgM, but are polyclonal and do not contain somatic mutation in their IgV gene. So we have to at least suspect, and then we have to go for a lymph node biopsy. Occasionally, these plasmablasts join together, they form clusters or microlymphomas and may progress to monoclonal plasmablastic lymphoma. It is suggested that histological confirmation with immunocytochemical staining for HHV8 or IgG lambda is essential for the diagnosis of MCD. Elevated serum level of HHV8 supports the diagnosis of MCD. So what is the treatment? ART has no impact on the incidence and outcome of the Castleman disease. Rituximab-based therapy has dramatically improved 5-year overall survival. This OS is overall survival rate for HHV8 MCD from 33% to 90%. Rituximab is used as a single agent weekly for 4 weeks in patients with adequate performance status and with the absence of hemophagocytic syndrome, hemolytic anemia, and end organ damage. The combination of rituximab and liposomal doxorubicin every 3 weeks appears to be attenuate Kaposi's sarcoma exacerbation. Rituximab with or without etoposide appears to be effective in HHV8, regardless of HIV status. So the recommendation is again, we have to confirm the diagnosis with HIV8 and IgM lambda, monitoring for lymphoma, because there is a risk of lymphoma is high in this patient. Rituximab as a first-line chemotherapy, and aggressive disease need to be treated with other agent. Retreatment with rituximab-based therapy for relapse disease. Plasma HHV8 level can predict the relapse, and clinical monitoring for the patient in remission should include the measurement of blood HHV8 level. Testicular germ cell tumors. Testicular germ cell tumors are non-seminoma as well as seminoma. So they are GCTS, means germ cell tumors are more frequently in HIV infection. Irrespective of the HIV serostatus, the testicular mass means it can be, should be suspected. So scan, MRI or tumor marker like alpha fetoprotein or human chorionic gonadotropin should be done. So what is the differential diagnosis in testicular mass? It can be orchitis or lymphoma. So a CT scan of the chest, abdomen and pelvis should be performed for full staging. So any mass patient is having in testes, we have to be careful. So these are the rounded typical nodular opacities observed in a secondaries, in a seminoma of the testes. The International Germ Cell Cancer Collaborative Group has divided into good prognosis, intermediate prognosis group, and poor prognostic group for non-seminoma as well as the seminoma. Now for non-seminoma, testes and retroperitoneal as a primary one. No non-pulmonary visceral metastasis. AFP is less than 1000. HCG is less than 5000. LDH is less than 1.5 upper limit of normal. So they have, if non-seminoma, 56% of they are the cases. 5-year PFS, that is a progress-free survival rate. So patient is having disease, but they don't progress. So this 5-year PFS rate is 89%, and 5-year overall survival rate is 92%. In seminoma, in 90% of the cases, all of the following criteria: any primary site, no non-pulmonary visceral, normal AFP, any HCG, any LDH, they have a 82 and 86%. So in intermediate group, again, testis or retroperitoneal primary, no non-primarily, AP more than 1000 but less than 10,000. HCG more than 5,000 but less than 50,000, LDH more than 1.5 or less than 10, upper limit of normal. This is the 28%, 75 and 80%, and seminoma 10%, 67% and 72% of any of the things. So poor prognosis, seminoma, no patient classified as a poor prognosis, but here poor prognosis, mediastinal primary, non-pulmonary visceral, AFP is high, HCG is high, LDH is high, then the survival rate is 48%. So what is the treatment for one? Only surveillance. For metastatic, standard therapy with bleomycin, etoposide and cisplatin with concurrent ART and antifungal. 4 cycle of standard 5 days BEP chemotherapy with the intermediate and poor risk group. Extensive pulmonary limitation from previous infection, then alternatively 4 cycle of EP or VIP chemotherapy. And if it is relapse, then high doses of chemotherapy with the autologous stem cell transplant. So recommendation, surveillance may be considered for seminoma of the testis, concomitant ART and infection prophylaxis. They should be treated in an identical manner regardless of the HIV status. Bleomycin may be avoided in a management of tumor with the PLHIV. So this is more concerned with the oncophysician. Non-small cell lung cancer. Non-small lung cancer, they are at higher frequency at the younger age, present with more advanced disease in HIV infected patient. Diagnosis is CT of chest, abdomen with special attention to the adrenals, along with the bone scan is advocated. So it should be done in keeping mind with the HIV viral load and CD4 cell count. What is the treatment? If operable lung cancer, then curative surgery. High risk of complications and recurrence are noted in HIV patient if CD4 is low. Locally advanced disease merits chemoradiation. Patient must be on ART and opportunate infection prophylaxis to be done. They are highly sensitive to EGFR targeting tyrosine kinase inhibitor. So that is to be used with the caution. There is no role of lung cancer screening in HIV as of now. So there is no need to screen for the patient. Hepatocellular cancer, we have learned this thing in HBsAg and HCV positive also. They documented that HBV and HCV co-infect in 11 and 30% of the PLHIV, in contrast to 2 to 3% with the non-HIV population. So diagnosis, sonography, AFP level, CT scan, abdomen. Then we have to go for this Barcelona clinic liver cancer stage. So they have given the staging from 0 to D. So 0 and A resectable tumor, and B is the chemotherapy, and C and D is a C and D is a palliative care therapy. So HCC, what is the treatment? We have to go if resection is possible. So with the this staging, we have to try. Liver transplant appears to be superior to resection alone in HIV negative patient, and HIV seropositive does not appear to be a negative prognostic factor for transplantation. This PI may inhibit the cytochrome P40 enzymes and interact with the immunosuppressive agent like tacrolimus, which are routinely used following the liver transplantation. Sorafenib has been well established for hepatocellular carcinoma in HIV negative subject, and it is equally effective. So when there is a HIV with HCV, HBV co-infected, we should at least advise 6 month alpha fetoprotein estimation even in absence of cirrhosis. So what are the immunological criteria for transplant? No age-defining opportunistic infection within the previous year, and CD4 is more than 200 or more than 100, and virological undetectable HIV viral load in at least last 12 months for HIV infection during the post-transplant period. So what are the recommendations? AP screening, carcinoma screening with liver USG should be offered. Hepatocellular carcinoma should be treated in the same manner, irrespective of the HIV status. Hepatocellular carcinoma in PL-HIV may be treated with liver transplantation if feasible, if the fits into the criteria. Sorafenib may be used as a treatment option in operable cases of hepatocellular carcinoma. Time limit is there? Okay. I think we have only 1 or 2 slides. Skin cancer. Primary skin malignancy are the most frequent known age-defining malignancies. The risk is higher for developing a non-melanoma skin cancer, and the ratio of squamous cell carcinoma to basal cell carcinoma in HIV infective individual is 1:7. Atypical features of HIV-associated squamous cell cancers are presentation at a younger age. They are unusual sun-exposed site, including mouth, genitalia, perineum, multifocal, aggressive, and higher potential for the recurrence and metastasis. Routine clinical skin examination and self-surveillance of skin in older PL-HIV are warranted in those with a history of skin cancer. What is the treatment? Although the conventional treatment protocol are acceptable for HIV-associated cancers, special attention to local excisional margin control, more extensive investigation for dissemination of the disease, and more intensive follow-up are mandated. A multidisciplinary team sensitized to the enhanced malignancy potential and higher recurrence rate must be involved in those patients. Basal cell carcinoma and squamous cell carcinoma have been reported to remit the ART. Topical imiquimod has been used for the treatment of basal cell carcinoma in HIV and is useful for the common scenario of multifocal superficial basal cell carcinoma. So recommendation is behavior counseling to PL-HIV with the fair skin to minimize ultraviolet radiation exposure to reduce the skin cancer risk, counseling on frequent photoprotective behavior and sunscreen use, regular examination, early treatment with a pre-malignant lesion. I think this is the last one, penile cancers. Penile cancer is 5 to 6 times more common in HIV. Risk factors are uncircumcised state, poor hygiene, smoking, and lichen sclerosis and HPV infection. Penile intraepithelial neoplasia and established penile cancer should be treated as per the standard guideline with preventive and curative tissue conservation and sentinel node biopsy occupying central roles. The recommendation for cancers is counseling about the hygiene and health. Routine circumcision is not advocated for the prevention. So this is to be kept in mind. However, examination of genitalia and circumcision should have a low threshold. I think this is the all for. Thank you. Thank you very much for calm hearing.
Thank you so much, ma'am.
This is literally a long, lengthy things, but suppose any questions or any queries there, welcome. We can have in chat box or later on also. Thank you.
Thank you so much, ma'am, for this extensive session. Requesting participants to please put up the questions in the chat box. Feel free to unmute your mic and ask questions too. Any questions from the participants? Please feel free to unmute your mic. Ma'am, I don't think there are any questions. Can we quickly run the feedback form?
Okay.
Thank you, ma'am. Kiran sir, can we have the feedback form, please?
Yeah.
The feedback form is now visible on your screen. All the participants are requested to please attempt all the 4 questions. With today's session, we have come to an end to the series on the national guidelines for HIV care and treatment. I take this opportunity to thank Center of Excellence at BJ Medical College and Civil Hospital, Ahmedabad, JJ Hospital Center of Excellence, Mumbai, and Pediatric Center of Excellence at LTMMC and LTMGH Sion for their constant support in facilitating all the RDLS sessions. Once again, thank you, ma'am, for facilitating today's session.
Thank you. Thank you from all our staff also.
Thank you so much, ma'am. Kiran, sir, we can end the poll now. Thank you to all the participants for actively participating in all these RDLS sessions and patient listening. We'll end the session now. Thank you, ma'am.
Thank you.